Hello, everyone. My name is Celia Wells. I'm the Senior Director of Nursing here at Mount Sinai Hospital for Critical Care under the Institute for Critical Care Medicine. I'd like to have my team introduce themselves.
Hi, I'm Rupa. I'm the Director of Critical Care Institute for Mount Sinai Health System. Critical Care Institute is a critical care organization that oversees 21 ICUs across Mount Sinai Health System and has various teams such as the Vascular Access Service, Rapid Response Team, a weaning program, and a post-intensive care syndrome clinic. And today we are discussing the work done by our Vascular Access Service, which places more than 10,000 catheters annually. Now I pass it on to our lead of Vascular Access Service, which is our nurse manager, Amy Brito.
Hi, everybody. So thank you. My name is Amy Brito, and as Dr. Poliseth said, I'm the clinical manager or nurse manager for the Vascular Access Service at Mount Sinai Hospital.
Hi, good afternoon. My name is Kester Brown. I'm one of the VAS RNs, and I participated during the pandemic, and we had placed central lines in the ICUs through this program, and we would like to share with you our experiences and our success during this difficult time.
So thank you, everyone. The name of the publication that we're going to be discussing today is the novel Multidisciplinary Vascular Access Team Helps to Improve ICU Workflow Amidst COVID-19 Pandemic. This paper is to describe the implementation of a multidisciplinary central line placement team. And so my question for the crowd would be, can you tell us how you came up with this novel idea?
I can speak to it. To remind everybody, we developed this team during our first wave of COVID-19 pandemic. That was in March 2020. We realized that we had scaled up our ICU beds from 104 ICU beds to 234 ICU beds and developed a tiered model where our intensivists were able to provide critical care to a large number of patients. We realized that central line placement for these patients was crucial and needed extra pair of hands to help out with the team. We recruited vascular surgeons, interventional radiologists, and our anesthesiologist colleagues to provide that service for us. We already had a vascular access service that is our nurse-driven service in place before the pandemic. So we recruited our nurses to help organize us so we are able to provide the care our patients needed at that time. So under Amy Brito's leadership, that Vascular Access Service not only did consults, coordinated care, informed the procedure list where the procedure was needed, and at the same time, helped out from outside the room and sometimes inside the room. If you remember, during our first pandemic, we were figuring out things as we went along. We did not fully understand the virus, and people were a little bit scared to go inside the rooms. So we decided that we are going to provide that extra support to our intensivists with the help of our vascular access nurses.
Thank you, Dr. Poliseth. Perhaps to someone else, maybe Amy or Kester, can you tell us that how you were integrated into this at the bedside during a national pandemic?
Yeah, I can speak to that. So in developing the team, we were able to recruit our nurses who were familiar with bedside placement and were able to quickly and efficiently coordinate the placement of these lines with the physician partners. We were able to have a sole cell phone line where our ICU teams were able to provide us with the patient information, which ICU they were located in. And then we were able to respond accordingly an approximate time that we would be there. And then we would work with a created a procedural cart where we had all of our supplies readily available, including all of our consent forms and documentation that we needed. And then we were able to proceed from there.
So who actually came up with the checklist and how to operationalize that at the bedside? How did you decide what things you would need, especially because at this time it was, it was very unknown. The territory was uncharted.
I think this just knowing, having the prior knowledge of what we need for each procedure, we were able to quickly type that up in terms of what supplies were going to be routinely stocked in that cart. So they were readily available for us. And then in discussion with our physician partners, what supplies they individually need. And so we were able to create a list for all of our physicians where we had that right in front of us, depending on which physician we were working with for that particular procedure.
Thank you. Kester, maybe you can tell us or tell us a little bit about the experience while you were going through this, what it was like to be in that moment, going into the rooms, working collaboratively with everyone, just giving everyone a feel for the whole experience.
Of course. The experience was initially very scary, but we relied on our extensive training and knowledge of the supplies and trust to our colleagues as far as their expertise in placing these lines. We would get, usually the order is we would get a call from these ICUs asking for the lines and their intended purpose of the lines. We would review them thoroughly, and then after we gathered enough information, we would then coordinate with our doctors who are anesthesiologists, vascular surgeons, and we would come up with a plan and say, we need to meet up at this ICU place. This patient needs this type of catheter, and this is their intended purpose of it. And once we're there, at that time, we are already prepared that we have a point of contact for the intensivists who would then verify all the information. And we made a rapport between each other, between the intensivists, the vascular surgeons, and the anesthesiologists, to know exactly the type of supplies and equipment that they need. And we would, within like, maybe I would say, in 30 to 40 minutes from meeting in the ICU area, prepping, and getting the line placed, we were able to accomplish that goal. This enables intensivists to take care of other patients who need their specialty, and also it helped minimize having other people go into the room and also save valuable PPE supplies that we were in shortage. It was scary at the beginning, but with proper coordination, trust, and leaning with our training, we were able to be successful with this project.
Thank you, Kester. That's terrific. It really shows how, when you have the strength of all the team members, how we could achieve many, many things. Looking forward, so we've come out of several waves of a national pandemic. There's a lot of innovative thinking and creativity. What is something you could tell other people about, working in a environment that's unknown? How do you get yourself to get to the next level? What was the driving forces? How could somebody else, let's pretend we have a new pandemic comes in, what would be your recommendation to people to keep in their mind and their focus? Anybody?
One of the things that I think, to kind of go along with what Kester was saying is collaboration, and really that strength of working together and what everybody brought into this program. And you have each other. If you had a question, you had somebody to go to. If you needed a little break, there was somebody there that was able to provide that to you. If you didn't have a specific supply, something that you needed, somebody was able to either get that for you or cover for you while you were able to go get what was needed. So I think really like working in that multidisciplinary team just made things feel slightly more comfortable and make things just very efficient. And so we could really ease the burden of our intensivist during that time.
I think vascular access is not giving themselves enough credit. So this service was already in place since March of 2017. So our vascular access nurses go evaluate patients, decide what the right access for the patient is, and then are able to send the patient or have an intensivist or other physicians come and provide the care the patient actually needs. For example, there are 3 branches to the vascular access service. There's a peripheral vascular access service, there's a central vascular access service, and there is a tunneled vascular access service. So our vascular access nurses coordinate all aspects of the care for the patients, and our physicians have gotten used to the idea that our nurses are coordinating care and they listen to our nurses. So pandemic was no different. This was already in place. So when our vascular access nurses decided and evaluated a patient and said, this patient needs a central line, they were able to get our interventionalists come to bedside and provide that care. Similarly, if patient needed a tunnel catheter, they were able to organize it. And if a patient needed a peripheral catheter, they themselves went in and did those procedures. So that was the beauty of it. They scaled up multiple times over during the pandemic. They were already set up for success.
So can perhaps Dr. Coley-Seth, you could tell us some of the outcomes or findings from the paper?
So vascular access service coordinated, as I said previously, various aspects of vascular access across Mount Sinai Hospital. And during this time, the workload of an intensivist in performing these procedures decreased by 46%. So they were free to provide care to multiple other patients. So vascular access in other ways increased our capacity to provide non-vascular care for our very critically ill patients, if that makes sense.
So this question is for Amy and Kester. Perhaps you could explain to everyone how this is going to inform practice moving forward.
I think being able to replicate this team easily and quickly will be able to provide a baseline for teams, whether it's vascular access teams, ICU teams, to be able to build this up quickly in even another pandemic or a situation where it's needed. Being able to replicate this quickly and efficiently would be able to provide a less strain on the ICUs and be able to free up your intensivists to be able to provide care to the sickest of the patients. This team, I'm really proud of this team and the work they did during this time period. It was very, very stressful. And there were a lot of unknowns and they persevered. Truly be able to take a burden and off of someone else to be able to provide care for those patients in a different way, I think just made a huge difference for our ICUs.
Just to add on what Amy had stated. I believe in the event another pandemic or wave hits us, and we see the same kind of negative impact on the health of the people. If our ICUs become flooded again, I believe this team can be revived very quickly, and I believe other institutions can adopt this same idea. It has the benefits of decreasing the strain of ICU intensivists in order to attend to other sick people. You have specialists who can come and place lines in a short, quick time frame, who are very experienced and trained. And with that advantage, you can provide quicker care to the patients who needs advanced treatments. And I believe with the knowledge of having a VAS RN who reviews and knows the type of catheters, the type of treatment, and knowing how to coordinate between different teams, I believe plays a huge role in having a successful team. And I think this was a very good program.
Mount Sinai Hospital has a very transformational leadership, and they saw value in vascular access service. So we were, the Institute for Critical Care Medicine was given resources to develop this team and to develop it to this level before the pandemic. I urge other health systems to have a similar process where they're enabling their nurses to truly work as partners with our physicians and be able to guide practice. It doesn't happen in a lot of institutions where nurses guide physician practice. And that is where we are different. And for other institutions to be at the same levels, they will have to do what Mount Sinai Health System does, where our nurses are at the same level as our physicians, and they can guide their practice and vice versa, and enable them to do their job better. So that's one way. I think there should be a transformational leadership that sees that vision to have a similar process across other institutions.
Well, thank you, everyone. It really was a pleasure to meet with this team again and talk about their one of many successes. And I think that as we move forward, we'll see much more very, very dynamic work from the vascular access team, as you know, their collaboration, their interdisciplinary partnerships will only help strengthen the relationships and the programs as we move forward. Thank you.
Thank you.
Thank you.